Welcome to Medical Grand Rounds. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous people. I acknowledge and thank the diverse Indigenous peoples whose presence mark this territory on which we now gather. I'd like to remind everyone to please enter your questions in the chat after the presentation, and please answer a brief survey that will be sent to you right after the presentation. This will let us know that you are here with us today. Finally, we have three speakers here. I'm going to introduce Dr. Michelle Kwok, our lead speaker, and I will let her introduce her residents that will be speaking with her. So Dr. Michelle Kwok is an allergist and immunologist, and she's based here in Montreal, and she works on her work centers on improving access to allergy and anaphylaxis care in northern, remote, and Indigenous settings. She provides allergy and immunology care to pediatric and adult patients in Northern Quebec through a combination of in-person outreach clinics and telemedicine, including ongoing clinical work with Cree Nation communities of Eeyou Istchee and through the Ungava Tulattavik Health Centre. The work is grounded in developing practical, equitable models of specialty care delivery with a focus on shared care, clinician education, culturally responsive practice, and local capacity building. She is co-founder of the Connexion Nordique, an initiative that supports allergy outreach and virtual care while working alongside local healthcare teams to strengthen sustainable services over time. And in addition to her work in Canada, Dr. Kwok has contributed to allergy education initiatives internationally, including clinical teaching in Rwanda, with prior volunteer experience in several low-resource and cross-cultural settings. She's currently completing the Oxford Global Healthcare Leadership Program supported by the Scholarship for Women. And I will let you introduce your other speakers. Thank you very much, Dr. Michelle Kwok, for being here today, and for all of you for being here today.
So thank you, Dr. Giannetti, for this wonderful introduction. I'd like to introduce to you two of my residents, Dr. Meng, R3 Internal Medicine, future allergist immunologist, will be training at UDM, and Dr. Marianne Rjeily, R2 Internal Medicine, allergist hopeful, and Dr. Michael Aw, who unfortunately could not be here today. I think I can change my slides. Okay, there you go. And yep, so this here is all of us on adventure. Michael, as you can see, joined me on a trip for 1 week in George River and in Tisuyak in Nunavik, and he's proudly holding his ticket. This is Meng in the Ungava Tulattavik Health Centre in Kuchwak, and Marianne, who will join me one day. And also, I'd like to acknowledge, again, the elders of this land. I do have connections to the Ganawake Reserve, and I've been speaking to several elders and community leaders who have really played a big role in shaping my understanding of Indigenous health, and also just getting their ideas of how my care can be more sensitive, as well as just helping to understand things that may seem frustrating to me, but actually, when explained to me in a different manner, it completely reframes some perspective. And these are my disclosures. I don't have any major conflicts related to this presentation. So I just want to imagine that you are here. This is Chisasibi. This was taken in February of 2026, and it was about -25, which would not have been so bad if it weren't for the huge winds. It was so cold that I could not even stand there for a few minutes. I couldn't hear anyone else saying anything at all. And this is a typical northern remote community that I go to. I've often traveled in winter times, and specialist care involves so many different moving pieces, like flights, weather, staffing capacity, like functioning transport systems. And like it depends on infrastructure that we often take for granted. And yet allergy still exists here. Anaphylaxis still happens here, and uncertainty happens here even more. This is Arctic char. It is a very important piece of food for both the Cree and the Inuit populations that I work with. They're often fished in the summertime, and they can be smoked, they can be cooked in any way, and they're usually shared with the community. And during one of the outreaches I had in Wotmagushtuwi, which is a Cree, it's actually both a Cree and an Inuit village. It's the northernmost Cree village, and also its twin town, Kucherapik, is the southernmost Inuit town. And so I met this young girl who had never seen an allergist before. And over the years, she just had accumulated a growing number of allergy labels. And it was to the point where she started having query reactions. She stopped going to people's houses to eat. She stopped participating in community activities, and that includes the smoking of the fish. And for her, like she restricted her food to basically junk food. And yet for her family, this matters a lot because she could no longer participate in anything that had to do with her culture. So what happens? Like many families, they just start to adapt conservatively. Where there's doubt, they just added more food to their list of things that they could not eat. And so for me as an allergist, it seems like a pretty straightforward case. You just test and you label and you tell her to not be scared and to eat the food. But the longer I worked in these settings, the more I realized that the clinical story is just a very small portion of what actually matters. For her especially, she had repeated nausea and vomiting after ingestion. Sure, it could be allergy. Avoidance to be safe, which happens to many people with food allergies. And more importantly, no access to allergy care. I also want to put this into a bit of context. This picture was taken in Kwok in 2023. And I want to highlight the cost of food that was up there. And also just, the pictures don't show it very well, but the food that I show, like not only does it cost a lot, like these 3 peppers are $6. These 3 pieces of corn are almost $8. This box of cookies that look like they could have been sold at Dollarama is almost $9. But these vegetables are basically rotting. They don't look fresh. Why would you even want to buy them? And therefore, when you put this in the context of food insecurity and lack of choices, it increases like even more the fear. So I decided to test her. Skin testing for me was negative, and then it sent immunocaps. And I just want to talk a bit about this lab test. So in Montreal, in a typical center, it takes me about 2 months to get these results back. Usually the government of Quebec decides to have specialized centers do certain lab tests for immunocaps, and the machines are run about once a week. So I expect to get my results in 2 months. The problem is when you're working up north, first of all, you have to find a patient because when you're seeing these patients remotely, or maybe you're seeing them in person, unless you get them at that exact time to do the blood test, you have to find some way to contact them, and it's rather difficult. And then you have to instruct the nurses on how to label them, what these things even are, the codes, and they all have to be written by hand. And then they have to be flown. Sometimes they get flown to MUHC first and then redirected to CHUM, and sometimes you just get lost. And I have had many blood tests that I got results 6 months later, but usually I never get the result. So in this case of this girl, I saw her in telemed first. I eventually did get some of my immunocaps. They're all negative. I did the skin testing and this was negative. And this is a plate of 4 different fish that I had her bring. And this is again where culture matters so much. This top corner over here, this is whitefish that her uncle fished. This is Arctic char that was in a freezer. This is just tuna sandwich. And this is another type of whitefish. Sorry, I think this was, I forgot this was, but this was traditional fish and this was the whitefish. They mix it with berries and traditionally they have bear fat that they put in. And if you think of it as like your original keto bomb, because if you go out onto the land for hours and hours at a time, you eat something like this to keep your energy levels up before you can eat something real. And then afterwards, I did a food challenge. And for her, like for those who don't do allergy, food challenge is like a way to where you introduce a certain food into their diet under controlled conditions after you do your risk stratification and see that the risk is low for having a reaction. And sometimes you can use that to prove or disprove there's an allergy or to see their tolerance level. For her, she passed. So therefore, I can the safety of her ability to eat fish. But more importantly, it rebuilt her trust around food. And it also allowed her to participate back in her culture and quality of life. I also want to show this picture. This is a picture of a medevac in Kangaroosuk, also in the Ungava Bay in Nunavik. And one day during my first trip in early 2023, I was up in a clinic and 2023 was not that long ago, but for someone who has gone repeatedly, in terms of technology, it's improved dramatically. I still remember there, it took me 20 minutes to load remote access on Oasis in the clinic using their internet. And that's because I had information that I was trying to look for and I couldn't find because it was never sent up into their chart. So I decided to page the services here. And the phone was passed from one person to another, and they couldn't quite understand my question. They had no idea what I was trying to ask. But the irony is, I actually know how the system works here. So you can imagine the frustration healthcare workers have up there when they're trying to get information and communication is broken. And this goes back to standard care assumes that infrastructure exists or work. And this can go for diagnostics, for staffing, for transport, continuity of care, and also for pharmacies. In many of the communities I go to, there is no pharmacist. They just have a medication stock, but because there's no pharmacist, it also restricts the kind of drugs that they can ship up there. And if you need something brought up, it needs to be expressly brought through Kwok, through one of their pharmacy partners in Montreal, and then given written instructions to the nursing staff there. And there's such a high turnover of staff and also people changing shifts that lots of information gets lost and you find yourself re-explaining things over and over again. And lastly, emergency response, such as this medevac. And then repeat follow-up. Even here, I know many of you have seen Indigenous patients and they always fall through the cracks. But why is that? It's because the system right now, as much as we're all trying our best to make sure that we continue to give them the care that they need, the system itself is so fragmented that it's very hard and takes a lot of motivation, but also knowing how things function over there to keep track of things. So I wanted to show you this note here from Chisasibi Hospital. And then the bottom line says, Allergy, been waiting for allergy testing for 20 years. This one appointment in 2011 was canceled. And again, there's a policy if you call patients 3 times, they don't pick up, then they're off the list. The problem is that many of the patients that I work with up north don't have a functioning phone number. And why is that? It's because they can't afford to pay their phone bill. So the way to reach them is you contact a clinic and they will have someone unofficially use Facebook Messenger to find them. I've also had experiences where they would go on the radio and announce that person's name and that the clinic is looking for them and they will come. So yes, you might think, okay, this is Indigenous areas, surely must be better elsewhere. This was me last week in Val-d'Or. This was my first trip up there, and my clinic of 9 patients had 5 patients that waited more than 3,400 days to see an allergist. So what is the problem really? Because when you think about access, like we think about geography, and yes, geography plays a very big role in this. But when you review the healthcare literature for circumpolar regions, first of all, there isn't that much. But even then, barriers to care is affected much more than distance alone. Yes, so geography, there's weather, there's transportation and physical isolation. By weather, I mean many of these patients, especially in the far north, they're in villages of like less than 1,000 people. And you're on a small plane of 20 people max. And by 20 people max, I mean that's if you don't really carry luggage. If you carry cargo, it might be much less than that. And there have been cases where people have been weighed and their luggage is weighed to see if the airplanes are safe to fly. But if there is any weather instance, like some kind of rerouting, like your flight will be grounded and then the patient will come maybe several days later, if at all. And there's workforce. It's very hard to recruit people to work up north because the conditions are so difficult. Nurses there usually have to leave their families behind, and doctors as well. Like they usually do several weeks on, several weeks off. But then the question is, what if they have a partner or have kids? There really isn't a school to send them to. So at some point, they come back south. But also with the retention, again, there's like the isolation can really be difficult socially. And then there's not much to do for fun because over there's not even a traffic light. There's no distraction, but also nothing to do. And then that really affects continuity of care. Coordination. Many of this, the only reason why things work up there is because people try so hard to make it work. But then that work gets absorbed and then nobody sees it. But it really wears you down mentally. And at the end of the day, that's not sustainable. And finally, culture. Culture first of all, in terms of when we work up there, we don't often get the training, like from a cultural sensitivity standpoint, or even an introduction to your culture. And with that comes language. When I work in Nunavik, I'm actually one of the few Anglophone people that work up there. The majority of the healthcare professionals are Francophone. They chart in French, they communicate in French. The only problem is that the patients are speaking English as a second language and Inuktitut as the first, and they most likely don't know French, which makes a lot of othering. And then that can also create misunderstandings and mistrust. And this is also on the greater background of colonial history. But then again, these are barriers that all work together and they reinforce and overlap. So I thought I'd talk about this. Like, this was a paper that I looked at. This was the best review I could find. It was not on telemedicine, it was on e-consult, because when you're looking at all these barriers for accessing care, the question is, why don't we just use telemed? I couldn't find a good one, but this one was e-consultation. I am on the e-consult platform as well, and that does facilitate things. But what's interesting is that this review of 72 studies, it was very heterogeneous. There's an I-square score of 100. And all the studies were very low or low quality according to their grade classification. So the reviewers couldn't make any conclusion other than we think that e-consult might help improve care. And I also tried to look for papers about nurturing communities for telehealth, as well as like circumpolar, Indigenous, like basically anything. There isn't much. This study, I think, actually, this wasn't even a study. This was just like an article. Another study had 6 papers. Again, couldn't make any conclusion other than we need more research, and we should have cultural sensitivity, and we think that it might work. But telemedicine is something that we have used. In fact, many of the subspecialties in medicine, as well as pediatrics and surgery, use it, especially in the Eeyou Istchee or the Cree territory. And I also use it sometimes for Nunavik. And sometimes is underlined just because in my personal experience, it's been very hard to do telemedicine in Nunavik, just because the people are so stretched. It is the same team that if an emergency happens, all of a sudden they all have to leave. In Cree territory, it's much more organized, but then it's also relative. Like if you're in the bigger communities such as Chisasibi, in Waskaganish, in Mistissini, who have like a dedicated nurse or nursing team that can facilitate all this telemed, and usually it works okay, even though sometimes I have half my patients not show up. But I've also had times where it's been a total disaster. I remember one time, all my backup mechanisms failed. Usually I message the specialized services for help and they troubleshoot everything, but both the nurses were on vacation. And then the person that was supposed to facilitate my clinic just happened not to be there. So I decided to call the clinic and it passed the phone around to every single person in the clinic trying to figure out who I was. Meanwhile, they're saying that all the patients are waiting in the hallway, not knowing that I was on the screen. And it said, please just log me in. So as you can see, like this is a hidden work that we all absorb. At the same time, when it does work, it gives you much faster access to specialists. It gives you continuity of care between your in-person visits and also reduce travel burden for everyone. This was like a very quick thing that we had pulled off from Oasis several years ago, which show like the telemed consultations in Montreal and Cree territory of James Bay and Nunavik. The thing is, you can see for Nunavik, almost 40% of people did not show up. And by telemed, in this case, we meant traditional call them, pick up the phone somehow. And it's because like, even if you have the ability to call them, access does not guarantee utilization. And whether this is like through Visio or through telephone, local context still influences uptake. And this local context usually is when you go in person and you talk to people, you understand and you see your face and they know you and trust you. That's when these things work. And then I also want to talk about why simple technology does not guarantee success. This is, for us, we use Microsoft Teams. What can go wrong? Yeah, so, wait, oh, I think I'm missing a slide. Actually, no, I think it's different. Oh no, something's wrong. Yeah, so basically, I was really happy that finally something came out on Nunavik. This was published by Pediatric Surgery at the Children's Hospital, and they did like a feasibility study where they interviewed 11 healthcare workers just to ask them, do you think telemed's going to work? Again, this is 2025 that we're able to ask such a question. And again, like their conclusion, again, other than like, yeah, we need more research and all that, is there is a very good chance that like people were really open. And interestingly enough, this what they did was something that also did for fun. The reason why I say for fun was because back in 2024, I was in different communities in Nunavik. I was grounded by a blizzard for 3 days. So no patients, no one was coming. We didn't know what to do. So I thought, why don't we just interview all the nurses and the doctors in the clinic and ask them what they think about telemed? And like this study is like a much more better presented way of what I did, but they all said, we think it's a great idea, but a lot of factors that people need to take into account. First of all, like it does take a lot of strain. You need someone to physically scan all the documents because in Nunavik, they're moving towards this EMR now. It's not quite there yet, and they're still trying to numerize documents, but I've heard that the organization is a bit difficult. So that's the hidden work that you absorb. And then you also have to get the people to agree to telemedicine. And then you want to have someone to feel comfortable because we're interviewing healthcare workers, but have you asked the patients what they thought and what they think and how they incorporate this technology and even how does this fit into their broader view of what health means for them? So this is George River in also this is like the most eastern community in Ungava Bay in Nunavik. And I remember one time I tried to do telemed, and this wasn't even in George River, this was in Kwok, so technically big-ish center. And I kept on asking, where's the list? Where's the list in advance? Because the secretary needed to register everyone into OASIS. And then they kept on saying, oh no, they've already been seen by MUHC. I'm sure they're in the system. 2 hours before, I still did not have a patient list. And they're like, do you want to cancel it? I'm like, no. I blocked off my entire afternoon and said, okay, we'll figure something out. So they had their liaison, an interpreter, go on Facebook Messenger and just message people to come. And I had a full clinic, which is great, but also super chaotic. And what does this teach me? Well, first of all, local context matters and local networks matters. Also, telemedicine, like as much as it's imperfect, it's really not a technology intervention. It's actually a health system intervention. And the success really depends on, first of all, on staffing, secondly, on communication pathways, and also on local workflows and organizational support, but most importantly, relationships. Because these interpreters and liaisons, like I cannot emphasize enough, like because they're language interpreters, but really they're cultural interpreters and they're bridge people. And that's also the other thing that the pediatric surgeon people had written in their paper that first of all, like you really need a bridge person, but also they can't count the number of interpreters, and yet their role is so undervalued. So that's why I say relationships are infrastructure. This is a team in Mistissini. This is Isabel and Marina, my nurses, and this is Sky, the interpreter, and Sunny, who is one of the nurses in another department. This one was just like a vignette that I had drawn about how you actually get a consult between telemedicine and in person. I won't go into the details other than it's super complicated. It doesn't really work very well. We try to optimize it, but it's still a work in progress. And the systemic factors behind that, I would think are another story for another day. But I just basically drew how we could have made it better and how really this depends a lot on streamlined communication. But I talked a whole bunch about the theory and telemedicine and anaphylaxis. But where do I actually work? So this top part here is called Nunavik. It is region 17 if you're going by the healthcare regions, and it's divided into two parts. So you see here, these yellow dots are the 7 villages or 7 communities in Ungava Bay, and these orange ones here are the communities in Hudson Bay. And this cross here, this is Kwok Hospital, and then this cross here is Preventative Hospital. And by hospital, yes, it's their biggest center. They don't have a CT scanner. Oftentimes you can only do basic labs, like low risk procedures, and everything else needs to be flown to Montreal. In these community centers here, they are run mostly by nurses. The doctors may or may not be here, but that's because the doctors get assigned to different communities and they're usually located at the hospital. So if something happens, like even a serious emergency, the nurse will have to call the doctor on call, give the orders, in more extreme cases, the doctors will have to sit on the medevac. But also, if you want to get a ride and your plane is grounded, you just volunteer to be on a medevac and you get your free ride. These green communities here are Cree territory of James Bay, and there are 9 of them. And Chisasibi is also their main hospital. Again, Chisasibi is it's more well-resourced, I would say, compared to the northern Nunavut hospitals. But even then, in many communities in the Cree territory, you can't even do a CBC. And I also just want to show some pictures. This is Kangasuk, the first Nunavut community I've been to. Kwok, super beautiful town. And then Watmagushtui Kuujjuaq, which actually Meng has been. And then Chisasibi, where Meng is going with me in August. And Mistisni, where I went in April. And then Kangasujjuaq, which is also went in 2023. And then Tasuyak, where I went with Michael in November. And Valdor, where I was just last week. Kangaswadashuak over here. Very difficult to pronounce. It's called George River. And this is where our outgoing Governor General is from. And then Rwanda, which I've been 3 times with Dr. Ghislaine Izabwe. And Valdor, which I don't know where the picture. Oh, there it is. That's a picture. So I just wanted to show you how much it costs to go there. This is my ticket from this year, which I paid out of pocket and got reimbursed later. But you can see here, it is $4,634. This is a 2.5-hour flight. This does not include going to the villages. And why does it cost so much? Well, first of all, I had to buy the Superflex ticket because in case of any emergency, I can cancel. But this is the reality of Northern outreach. And this is a hidden cost that we also don't see when patients get flown down here. And I pack usually all my food. Depending which community you go to, you don't really know the availability of food, you don't know the price of the food, but also you might not have time to go buy food, especially if the store closes at 6. This is a plane, one of the planes I went to in between the communities, and you can see everyone is wearing their jackets or their parkas because it's a charter plane. So it might stop every 30 or 40 minutes. You open a door, it's -30 outside, gets really cold, and then you have to go back. This is loading the suitcases from the plane into the truck, and you just pick it up outside the airport. And this is the CLSC for George River. And this is already a big CLSC. This is my makeshift workspace. I saw my patients in the x-ray room because there was no other space available. So I wanted to switch gears a little bit and talk about pollen food allergy syndrome. I'm sure many of you have seasonal allergies and they are very annoying, but it usually doesn't affect you more than that. And this is a chart that we show allergy patients, and we just tell them that sometimes if you have some tingling in your mouth because you ate certain raw fruits or because you ate certain nuts, it might have been because your body thinks that the proteins that are present in these foods are related to the allergens in certain pollens. But this becomes a problem when you're working up north. And you are in a limited resource setting, and also people have multiple allergies. This was a real case that I saw 2 years ago, and this girl told me she was allergic to about 14 or 15 different fruits and vegetables. And I thought, okay, sure, you're just being picky, whatever. I will do the testing. But it turns out she was actually allergic to many, many things. And not only that, I decided to do a challenge, and she actually did react. This is actually her getting much better after we gave her lots of medication. But with more pressure on me because there's a funeral in the afternoon, and 100 of the 600 people in the community went to this funeral, and I had to fix a reaction by then. But what really happens is, when I went up there, I thought, okay, this is just one case, surely there can't be more. I realized that a lot of patients in both the Cree territory and in Nunavut experience a lot of pollen food allergy syndrome. And at the same time, there's increasing evidence that climate change is altering exposure patterns. Because first of all, pollen seasons are becoming longer because it's warmer in spring and in fall. There's a lot of pollen that's being increased. They're more allergenetic. Pollens are flying in places where they're not supposed to be geographically. But this becomes a real problem when you're working with vulnerable populations who may not have the best health literacy, who may not be able to access the proper health care, and who might also have adverse experiences of childhood or other social or psychological factors that influence their care. So with that, I'm going to hand it over to Meng.
Perfect. Oh, I think this is
actually, these are my slides.
Yeah. Well, I'll come. No problem. So I'm here to talk a little bit about ongoing project we have started last year, actually, and still ongoing. We saw in our outreach clinic, we had a lot of pollen food allergy, but also environmental allergy. And then we were looking, it's like, so what exposure, what pollen is there up north, and what data do we have currently? Looking at that, we saw here in Montreal, for example, we have the Arab Biology Lab that does constant pollen monitoring, and we have a good calendar of the pollen throughout the season. We know that, the trees come somewhere and during the spring and then follow by the grasses and the weeds during the summer and the fall seasons. And then the same thing we have access to with the spores and fungal spores data. However, in Northern Quebec, there existed no such pollen monitor above kind of the northernmost we could found was actually in the Quebec City area. So we didn't have any data from up north. So before deciding what to test these patients, what to counsel them, we needed to answer the question, what's actually in the air up north? So that led to the question led really to the Northern Pollen Monitoring Project. And then really that data we wanted to guide testing and counseling and bring it back to clinical practice. So looking at the project, we really wanted to establish a local aeroallergen surveillance. We chose Kuujjuaq as our first pilot site. And then that's for many different reasons, because we already had experience and knew the local partners there. And there's already a set up healthcare infrastructure so that when we can come back with the data to do the clinical translation of the part of the project. And then also environmentally, Kuujjuaq is very interesting because it does sit at the transition line of the tree line between the tree tundra and then the shrub tundra. So that's also why we chose that as our pilot site. It's not meant to represent, the whole Nunavik area, but really as a first site, a place where we can see how the model works and also expand later on from there. So really, we collaborated with Biology and Makavik Research Center, and we set up a pollen monitor seen here to be installed in Kuujjuaq. We had a local retired researcher, Dr. Michael Kwok, who helped us out to collect these kind of adhesive rods where daily would collect the pollens that were in the air, and then daily we would send it also in a bunch back to this laboratory for analysis. They were stained, scanned, and counted, and then reported to be converted to kind of standard measurements of particle per cubic meter. And then we set up during the whole 2025 season. So once it was displaced, we were able to generate this data. Again, before diving into really the results, I want to frame this as, again, it's a preliminary single season, single site study. So it's not to really generalize the trend yet, but we're hoping to kind of from this to really just gain an understanding what was in the air, how different it was to be from Montreal and southern Quebec, and then just the feasibility of the monitoring site. So during the season, we sampled about 186 days from mid-May to mid-November. Diving into the data, what we saw, the main pattern is that in Kuujjuaq during this first season, the pollen peak was very concentrated, mainly in the end of June, a little bit in the beginning of July, with the peak pollen concentration being measured on June 28. In contrast, the fungal spore was more abundant overall, but they also had persisted later through the summer, the falls, with kind of this multi-wave pattern. Diving into the breakdown of more the pollen phenology, it was mainly driven by tree pollen, actually. About accounting 90% of the pollen captured were from trees, 8% from grasses, and only 1% from weeds. And then that's different a lot from the practice in southern Quebec, where our testing panel included a lot of more grasses, ragweed as major components. So when designing our skin testing panel, we wanted to prioritize here the trees because of what was reflected on the data. The next question is, which tree was drawing the tree pollen signal? Was it different from Montreal? So what we could see from this first season that the dominant pollen taxa was alder and birch, accounting about 82% of all the pollen captured. And then together, it's very clinically relevant because they both contribute to allergic rhinitis symptoms, conjunctivitis symptoms, but also birch-related sensitization can be tied back to pollen food allergy syndrome. And now, once we knew which pollen dominated, the next question was about what timing of these exposures. So looking at the data, we saw, again, the alder and the birch, which were the main one, really peaked at the end of June, and then smaller contribution to the weeds, from the weeds and the grass, but they do extend a little bit later into the summer and early fall also.
Now, looking at the fungal spore data from this first season, it looked very different. We're detecting about almost 97% of days we sampled, compared to only 37% of the days for pollen. Instead of one short peak, they're kind of multi-wave, and then extending to July, August, and also September. And then the fungal spores are also important in our data because of the broader environmental context for asthma control, respiratory health, and late onset symptoms also. Looking at the composition compared to Montreal, where we're used to a broader spore season with familiar taxa like Cladosporidium, Alternaria, Aspergillus. Here in Kwok, during the first season, what we saw was the kind of a major spore burden came from miscellaneous ascospores and basidiospores. And then so the composition, both in the timing and also the compositions differed from a bit from what we could see in Southern Quebec. This is just an overview, kind of summary of the season at the first season at a glance, where on the left side we see the pollen burden driven mainly by the trees and happening mainly in June, and then over the fungal spores, which we saw throughout July, August, September, with the main being also in September. And that brings us to the bigger question: how is it different from Montreal? From this first season, what we can see that Montreal has a broader, more familiar pattern where we're aware a mix of tree pollen, grass, and then ragweed, the long fungal spore season. And then Kwok first seems very compressed, much shorter, and then mainly driven by alder and birch. And then the grass and weed pollen, very small contribution from them. And then in terms of the broader spore type, and then both the timing and composition was a bit different than in Montreal. This is really, the slide's more about kind of the implementation. We looked at this first season collection, and then we wanted to ask ourselves, is this something that could be repeatable, can be kind of survive real world challenge in remote northern communities, the weather, the shipping, the staffing, etc. And then really this first season suggests that, yes, it's something that can be repeated. Only 5 of the daily records were flagged for quality issue data. Either they were not received, they're blank rods, some dirty rods. So that's represent about 2.7% of the 186 observation that we did. And then this is important because we wanted to be really clinically useful, and then we wanted to be something maintained over long term across season, and hopefully expand to different community also with this more pollen monitor being set up in northern communities. And finally, so this is where the data really came back for us into clinical care. So in November, we were able to do a week-long allergy clinic in Kwok, and then it was really guided by the local allergen surveillance data. So when we were selecting our skin testing panel, we made an emphasis on alder, birch, pine, and fungal allergens. We were able to evaluate these patients and then interpret the positive test in context, and also provide counseling around it. We also were able to visit the active pollen monitoring site, and this is Dr. and Michael Kwok, who really helped us out during this season, and then also established local partnership, and then able to visit also the MUHC Research Center, which was also very enriching and contribution for long-term partnership for us. So. And finally, the final piece is that knowledge sharing. So we're making sure that what we learn, the data we collect about these communities are not just staying in academic presentation, but they're shared back and given back to the community. So as part of this project, we also collaborated with a MUHC publication, kind of a publication magazine, and also electronic, where we kind of wrote about pollen monitoring project, why it matters, and education about environmental allergies. So really to close off the pollen project, it's something that we're hoping to continue long-term and expand in the future. And then the same issue kind of really reflected here is that care in the Northern Indigenous community cannot simply rely on the assumption in Southern data that applies to the North. And the same principle guides us to the next project that my colleague is going to talk about on anaphylaxis.
So I just wanted to introduce a little bit more. I did not see these notes when I first saw the patient. I was just on a regular telemed in West Wanepe, I believe. And I was just told, oh, the coordinator is also a patient. She had anaphylaxis, and she told me in kind of French that she had some kind of bad reaction to an antibiotic, and she thinks it's clavulin. So this is me having read the notes finally in person when I went to Miss Dissany to see her about 2 months later. And it looks here, basically, she did have an anaphylaxis, like her BP went down, like, all her vitals went down. She needed lots of Cymedrol, saline, Reactin, Epi, everything. And so I finally saw her, and and by finally saw her, I'm basically compressing everything. I actually had to write a very long protocol, just because, again, I'm working with a group of nurses and doctors that are not familiar with allergy testing protocols. These are all assumed when you're working in an allergy center that's specialized. The medications, I ordered it myself, and a pharmacy said, well, we're not mixing these. So we had to look up ourselves how to mix up the standardized concentrations to do intradermal testing. And also the risk factor, because she came from 2 hours away. So I had to make sure that whatever it did was okay from a risk perspective, because if she was stuck on a road in the middle of nowhere with maybe or maybe not a cell phone reception, and she had a reaction, then that would also be not good. But I did do an intradermal testing on her, and she was quite positive to all the beta-lactams. I tested into clavulin, and it concluded, okay, please don't take any more penicillins or clavulin or amoxicillin. And I challenged her to ceftriaxone just to give her another option for antibiotics, and she passed. And these are just my notes saying what I had done. But it goes back to the next topic on anaphylaxis, which I'll hand to Marianne.
So why are we talking about anaphylaxis? It's really because it sits at the intersection between allergy, access to care, and health equity in northern populations. And so anaphylaxis, we don't only talk about an acute medical emergency, but it's a condition where early recognition and access to care really impacts outcomes. And so why does this matter? Is because anaphylaxis is increasing, especially food-triggered reactions, and epinephrine remains underused. This is also important because epinephrine use goes beyond just using the medication, but also goes into having the medication accessible. And so is this medication accessible to these patients? Are they able to recognize what they're reacting to, and can they administer the medication? But another issue that presents itself here is that we don't know what patients are reacting to in northern communities. The majority of the data that we have really focuses on areas that are easy to study. So patients who either have coded emergency visits, who are associated to medical institutions, and connected to research networks. And so remote and Indigenous communities, being as the data is not easily accessible, they're not represented in our research as well as other patients. And so in order to be able to study what triggers are present in the north, what we have to work with is multiple different community organizations, including the Cree Board of Health and Social Services of James Bay, the Nunavik Regional Board of Health and Social Services, individual clinicians, but more importantly, community members and patient partners. This work we are currently developing in collaboration, not really just only as an external project, but more as a project that we are working in collaboration with the community. So all the partnerships that I spoke about earlier in the previous slide, as well as our community partners. So what we really are trying to understand is the local anaphylaxis pattern. So who's reacting, what are they reacting to, and what happens after they present to the emergency room. What are the barriers to emergency allergy care? This could go from geography, transportation, medication availability, clinical staffing, and other barriers. Access to epinephrine and access and use of epinephrine when necessary, but also culturally relevant education needs, because understanding this information helps us better tailor our education and what becomes available and what becomes covered in these communities, and as well for opportunities for prevention and continuity of care in these populations. So right now we're really at the governance and access gate. So we've collaborated with the ethics board in order to try to look into the feasibility of doing a retrospective project. Right now we have a meeting on July 9th in order to further discuss the ethics. But looking at the feasibility of the project, there's about 2,500 visits per year. Unfortunately, they're not coded on presentation, but we do think that there are ways that we can work through this, whether looking at allergy flags or at archives in order to look at the charts. And then really working with local partners in order to see if there are any current local things that we can do in order to further validate the case finding and work on the project.
So, talked a lot about science, talked a lot about outreach, telemedicine, anaphylaxis, but really, what does this teach us? So, I want to show you again, this is Tasiak in Nunavik. And basically, access is not separate from care. Access shapes care itself. And through these projects and through all my experiences in Northern communities, I came to realize that access influences not only whether care is available, but also the type of care that can be delivered and the continuity of care, and most importantly, the relationships that shape it. And this applies whether to if you're coming in person or using the e-consult platforms or using telemedicine, whatever that may look like, or even all the initiatives that we're exploring. One thing that I'd like to mention is even though we presented that we're working on ethics, this process has been going on for a year and a half. We're still not there yet. And that's also because my experience with trying to pass ethics for a project in remote Indigenous settings has completely turned upside down my understanding of science. Because yes, it's really nice to design a project, to have a protocol, all that, get funding. But what about the people you're working with? Does it actually matter to them? Are they going to get the results back? More importantly, is it something they care about? Do they know who you are and do they trust you? Because if you don't have any of these foundations, it doesn't matter how good your science is, it's not going to work. And so therefore, so basically, like any intervention we want to design will have all these communities in mind. And with that, I also want to acknowledge some of these people on our team. Dr. Moshe Benchashan in the Montreal Children's Hospital in Division of Allergy and Clinical Immunology. Dr. Jennifer Prodiger, who is a food allergy researcher in University of Manitoba and has worked with Indigenous populations in her own area. Dr. Michael Kwan and Dr. Noah Brousseau from the Nunavik Research Center, as well as our Deanne Naylor, who is our clinical research coordinator, and in Nunavik, Guy Bergeron, and all the liaison team at Kuujjuaq Hospital, Dr. Nathalie Boulanger, who is DSP of Ungava Bay, Andrea Hua, who is our Indigenous partner in Kuujjuaq, all the nurses and interpreters, as well as an Eeyou Istchee, Valerie Alemont, David Dalva, all the nurses that worked with me there, Jennifer Morrill, and then obviously Dr. Michael Fine, Dr. Chris Sukis in the Division of Allergy and Immunology, as well as all the residents and trainees who have been involved in some capacity. Dr. Adora Mir, Dr. Miriam Aldaba, Dr. Badra Alkamezi, Daniel Benchashan, who is a PhD student in Laurentian University, Megan Park, who is starting her dermatology training at Toronto, Miriam Al-Alawi, who was working with me while she's doing her master's in public health here, Dr. Clara Long in GI training, and Dr. Megan Canu, who will be starting internal medicine at UDEM. And I want to say thank you very much. Please read my blog.
Thank you. Thank you. Really interesting presentation. Congratulations. You're all so brave and persistent and really, really well done. Congratulations. Yes.
Well, thank you very much for this excellent presentation. Very informative. I happen to be in charge of laboratory services for Regina and in charge of laboratory services there. And due to the long turnaround time of the specific IgE, some done here, some sent to Shu. And also, I know there's some new allergy testing on streets. Do you think it's worse to develop the street testing at the Chisasibi laboratory or even at community as a point of care, testing?
So actually, I haven't heard about these strips. Can you tell me more about them?
Well,
So,
yeah.
in recent years, because of allergy test, they have, quoted a lot of, different antigen on the street. It's like testing. And then instead of, putting sample inside the instrument, FADIA in the case for allergy testing. And then they can use some, strips. And then you have your patient's serum drop on the strip and see whether there's any line to show the connectivity of,
she wants you to repeat the question.
Oh, okay. Yeah, so basically the question I was asked was, what is the feasibility of using allergy testing strips instead of sending specific IgEs as they're quite problematic? I think the answer to that is it really depends on a workforce capacity, because I depend on nurses to do everything in these facilities. And even trying to do IgE, I thought it was simple. I thought I would just have to adapt a form that I use and upload into their system and click the boxes print. And then I realized that even when I printed it, the nurses had to write everything by hand or type it all themselves. And then they had to speak to the lab to figure out what to do. And then I had tried to ask them to send to the SHUM, because I know that SHUM does a lot more than we do here. But then by their protocol, it must be sent to MUHC first, and then we route to SHUM, and from SHUM to Laval if there are other things that can't be done there. So I think my answer is, if the lab is able to do that, if it doesn't put too much burden, and that's the one thing I'm always aware of. Like, I know that whenever a specialist comes up to visit northern areas or to do telemed, it's actually extra work for the team, because they have to support, and then everyone has a different working style. And then also what sounds very familiar to me may be complete Greek to them. So I think that would be the main issue.
Well, if you can send me a full list of the allergy you want to test, I probably can contact the manufacturer to see whether they have a straight-based allergy test. So if they do, then maybe we can develop either in-lab testing using strip or point-of-care strip testing.
Yeah, yeah.
So I'll let the two of you maybe finish this conversation. It's a very important conversation. Thank you. We can maybe finish that offline. Are there any other questions, Joyce Pickering?
Just a question about the tree allergy. I was surprised that in Kuujjuaq, peat allergies were so common when there's hardly any trees there. So when you go further north and you're completely north, do the tree allergy people still have tree allergies?
Yeah, so I'm just going to repeat the question for Zoom. Dr. Pickering was asking about if there are tree allergies in Kuujjuaq, which is just below the tree line. Yes, I was very surprised. In fact, what was the number we quoted? 40%, right? Yeah, 40% of our patients I saw there had tree allergies. One of the reasons is because they actually get flown south a lot for medical care, so they are exposed. But the other reason was why we're starting to do the pollen counter, because it didn't make any sense to me. I do think that the wind patterns and the changing climate has something to do with that. But that leads to another thing, which is we are applying for a CIHR grant to examine this more, because we already have data for all of Canada for anaphylaxis in the major centers at least. And we were doing the extension of C-care study in the northern areas. So we wanted to correlate the anaphylaxis with the pollen allergies and the pollen counts and see if there's something going on.
So, but when you go north of Kuujjuaq,
Yes.
still allergic to trees?
Yes.
No.
The wind.
Yeah, the wind.
Maybe it's the wind. Okay, are there any other questions? Dr. Roger, yes.
Yeah, thanks for this great work and the outreach. I wonder to what extent budget ever becomes a consideration. You've mentioned workforce and access issues and sort of cultural and sort of the realities of daily life. But do you or your colleagues that work in these rural communities ever hit a budget wall? You haven't brought it up, so I just kind of wondered if the financial resources there was the human resource. Sorry.
So I don't have, I should just repeat that, right?
Yeah, sure.
Yeah, so Dr. Rogers is asking about whether budget was an issue and like something that a wall that I hit when I do my outreach. I don't have any recent numbers on budget. I just know that before COVID, it was about 107 million. And in Nunavut, as well as any northern region, I know in Nunavut, 40% of their healthcare budget is spent on medical travel. So the way I argue it is no matter what I do, the fact that I'm actually going up there to provide a care will save the government a significant amount of money than having people flown down.
What's the, do you know how much more or less per person, like to fly somebody down? Because you just showed us your
Yeah.
airline ticket, but then there's a hotel stay or
Yeah.
a little bit, what?
So
Again,
again,
for you quote sort of per person visit into city, into town.
the number that I had unofficially given by Cree territory from like Chisasibi was about $2,500 for one patient. But then again, the part that I cannot see is when I fly up there, I'm buying a regular air ticket, but they have different pricing for different patients who are Indigenous, as well as the escorts, and then their lost income, and then the places they stay. Usually for Cree people, it's Espresso Hotel, and then for Nunavik patients, it's Uluvik. So those are already there. And then transportation like that is already there. So this is a question I'd probably have to bring to like either Christina Biron, who is like the head of the Cree Health Board, and then for Ungava, I'll probably ask Dr. Boulanger.
Thank you very much. If there's no other questions, we're actually coming up on the hour, so perfect timing. Thank you. Congratulations on the great work that you're doing up there. We really need you to be doing this. So thank you so much, and thanks everyone for attending. Just a reminder, this is the last medical grand rounds until September 8th. I wish everyone a wonderful, safe, and enjoyable summer. Thanks for joining us over the season of grand rounds. Bye.